Morning, Amit, and all of us joining us from Mumbai. Is audio video all right? Can I start?
Yes.
Yeah, okay. So we had a healthy debate on whether to have LCS or not screening program. But first, I will address how to approach a lung nodule which has been picked up on a lung cancer screening, and then contribute perhaps my 2 bit to the debate at the end of my. So the program, just like we have RADS guidelines everywhere, we have similar RADS guidelines for reporting the screening CT scans which are done under the LCS programs. Currently, we are supposed to follow the version 1.1. The first version came out in 2014 and 1.1 came out in 2019. And since we are discussing, incidentally detected nodules, I will clarify this issue later, just to say that Lung-RADS as such cannot be applied to any nodules outside of a LCS setting. Having said that, it does contribute a lot to our understanding of pulmonary nodules and their likelihood of being malignant. So it is not to be used for lesions detected on any other CT studies. At the end of assessing the CT, we give a Lung-RADS score, cancer screen. You label it as a positive screen or a negative screen and then suggest a further action. What are the components whenever we evaluate a lung nodule under the Lung-RADS program, and basically for every nodule, is basically consistency, size, growth, and additional clear-cut benign features and malignant features. Consistency is something which has really come up in nodules, which means that you label a nodule as being solid, part solid, or ground glass. So amongst these, the purely ground glass nodules, are relatively benign lesions, likely to have no growth, less growth, or being infections and other causes. That's why a positive screen for non-solid or GGO nodules has been kept at 30 mm. On the other hand, if you have a solid nodule or a part solid nodule, this size for a positive screen has been kept as 6 mm. The definition of ground glass remains the same, that if you can see vessels or bronchi through that nodule, it gets labeled as a GGN rather than a solid nodule, and a PS or a part solid will have part of a ground glass, part of solid. These two put together are also referred to as subsolid nodules. Then what is important is on size measurement. How do we measure the size? So you would take two largest diameters perpendicularly, take the average out. So these are the two diameters, divided by 2 and express it to 1 decimal point. As we go and see the various Lung-RADS categories, the ground glass and the solid component needs to be measured separately and reported separately. So that is with the measurement. We come to growth. Again, growth is defined as an increase in a diameter of more than 1.5 mm. But what we need to remember is that when we deal with subsolid nodules, the size is not the only important thing. We also need to follow sequentially the attenuation. If the attenuation increases, that means the nodule becomes denser. That also goes into a suspicious nodule. Or if a new solid component comes, or the solid component itself increases while the overall size of nodule remains the same, these are all labeled as growth. Looking at categories, very similar to the other screening reporting systems, 0 means incomplete. Now, what are the clearly negative or benign features which have been given? So the patterns of classification, if we can remember with the 4 C's, complete or central or popcorn or concentric, all of these or any of these patterns or presence of fat within a nodule is when you can clearly put it inside in the category 1 or negative screen. On the other hand, when we come to the benign nodules, which means very low likelihood of turning into cancer, as I mentioned, see in solid nodules, this size remains 6 mm, in PS also 6 mm, in GGN it remains 30 mm. There is a new entity which comes here, which is the periphyseal nodule, which is often mistaken for a nodule and reported and is actually a node. I will address a slide later to periphyseal nodule, but in periphyseal nodule, there is a size threshold of 10 mm, which is taken as benign, and more than that, this also becomes suspicious. But if you notice that when there is a new nodule, this 6 mm drops to 4 mm. So if there's a new nodule which you have detected, then 4 mm is also significant. Similarly, the category 3 or the indeterminate ones with the 1 to 2% likelihood of being cancer goes in size category 6 to 8 mm. Here if you see, once we reach Lung-RADS 3, the solid and ground glass component starts to be separated. You mentioned the total diameter separate and you mentioned the solid component separately. Similarly, in the suspicious nodule, basically the size keeps on going up. We now reach 15 mm for this, and part solid nodules also, you mentioned separate solid and ground glass component. Endobronchial nodule is the new component, and no pure ground glass nodule makes it to category Lung-RADS 4. So only PS and solid are left here, and no pure ground glass nodule makes it here. So this is a 5 to 15% likelihood of being malignant. The very suspicious nodules with or without other morphological features which suggest malignancy, and herein it means basically any solid nodule more than 15 mm or solid component more than 8 mm is going to require further evaluation, and most nodule which is this large actually, unless it shows the clearly benign features mentioned in Lung-RADS 1, will require sampling. There is a modifier S, which means that you report when you do lung CTs in smokers, you are going to pick up so many other things, which means you will pick up emphysema, you will pick up ILDs such as RB-ILD, DIP, UIP, and you will pick up coronary artery calcification. So all these can be added in the modifier S. In addition, if you pick up things in abdomen and thyroid, which have been included in the scan, those also go under modifier. Periphyseal nodules are very characteristic by their appearance because they are this ovoid and oriented across the fissures. Having said that, it's very frequent for periphyseal nodules to be reported as nodules, and it is to be understood that this differentiation is very difficult to make on films, and it's essential to see this nodule, its shape, because under the Fleshner Society guidelines for this PFN, many things have been defined as its shape and orientation. So it has to be seen in all three planes, coronal, sag and axial, before we can give it a clean chip. But less than 10 mm, clearly PFN will go into a negative screen. So if we look at these categories, this estimated risk of developing cancer is only in the following year. That is why the Lung-RADS categories cannot be applied to incidentally detected nodules, because this categorization assumes that the patient is going to return to you in a year and you are going to repeat the scan. You only need to specify if you need to do something differently. But in a real life setting, when there are incidentally detected nodules, the patient is not going to return to you in 1 year. So that's why the guidelines and the recommendations will differ. LR1 and 2 go under the negative category, and 3 and 4 go under the positive category. Let's just look at a couple of examples before we wind up. 62-year-old male, 35 packed ears, complains of hemoptysis. This is the nodule which is detected. What should you place it under? So this is a solid nodule, we can see. We know these are our size criteria. More than 15 mm, speculated margins. So should it be 4? Patient already has hemoptysis. So patient should have been, you should have looked for CA lung in this patient anyway. So it's not a screening exam. But the same thing if you were doing in an asymptomatic patient with say 40 pack years and it was a part of a screening exam, then yes, this would go into a 4X category. So that's the difference to be understood. And similarly, new nodules. So this is a previously normal LCS. If you first detect this nodule, it will not be significant. It's 7 mm in size, but because the last lung screening exam was normal, now a 7 mm nodule will place this into a 4A category. Similarly, this is a 33-year-old patient, has a part solid nodule, GG component is 25, solid component is 10, places it under 4B. So this is how we need to report. The recommendations to summarize: 1 and 2 are negative screens. They continue with LDCT. 3, follow up at 6 months. 4A, follow up at 3 months or FDG PET. 4B and 4X, you definitely do a full staging exam and biopsy. So there are gaps, that you can detect so many other things. And while there is a guideline on the S modifier, it's not very clear. And different institutions report it differently. Are there any other CT reporting systems for LCS? There are, and different countries may follow it, but the most prevalently followed is Lung-RADS, and in the US, at least that is the only one which is authorized by insurance, so that's why that's picked up the most. Future directions, we are moving towards ULD CT, because we want chest radiographic equivalence in doses. At the moment, ULD CT is not approved for lung cancer screening because ULD CT is not available in most of the scanners across countries because it requires an iterative reconstruction, which is not there, is at the moment available only in high-end scanners. It's also being called screening for Big 3 or Big 4, which means that you report all this also on the scan, and AI-based assistance will definitely be required.
Madam, there is one question for you. So, what do you think when the residents are looking for the screening chest? So, what are the high-risk features you will suggest that has not to be overlooked?
See, high-risk features remain the same when you get speculated margins and etc. All the signs which we described for a peripheral lung cancer. Having said that, more than a 15 mm nodule basically needs to be sampled unless it's showing clearly benign features. And amongst these, the part solid nodules are said to have the highest risk of malignancy. So that's the one you have to really watch out for. But what happens in ground glass nodules at least is that when you repeat the LDCT as 3 months, a lot of them are going to go away. So to just reiterate again that in an Indian setting, you may not be reporting a lot of these things under the LCS programs and they may be incidentally detected nodules, then the course of action may be different because, if you are strictly doing it under the lung cancer screening program, you can stick to the Lung-RADS descriptors.
Second thing, the thing is that because these nodules are very small and the chances that we get what would be the strategy in that particular scenario? So whether they will directly undergo resection in that particular patient?
Upfront resection. Amit, we send a lot of them for upfront resection if we even anticipate that it has very high risk features and you're not likely to get, it's not accessible. There are many situations like behind the scapula, and however much you may try, you're not getting a route. Then taking the patient into confidence, communicating the risk of lung cancer, it's better to go for upfront resection. I've never seen a patient really refuse surgery on that ground. All these ones with highly suspicious features, especially the PS nodules, have all turned out adenocarcinoma. So, but another thing in incidentally detected, I'd like to reinforce is that ask patient for any previous study. It sounds like a very commonsensical thing. But from the time that patient was born, if he has done any CT, if the nodule has been there for a while, it solves your problem. Otherwise, biopsy, negative biopsy or nodule for whatever reason not amenable to biopsy, it's better to go for an upfront resection, because at that point patient may need a sublobar resection or lobectomy, and subsequently, adenocarcinoma may grow. Most of these PS nodules and these things are adenocarcinomas.
Thank you so much, ma'am, for the illustrative lecture and taking time out for this Sunday. Thank you so much.